Hello, I'm Norman Fenton from Risk and Information Management Group at Queen Mary, University of London. In this lecture, I'm going to talk about our ongoing analysis of the latest data published by the Office for National Statistics on mortality by vaccine status in England. Now, the reason this data is incredibly important is because it potentially provides us with the simplest and most objective way to determine the overall risk-benefit for COVID vaccines, namely the comparison of all-cause mortality between the vaccinated and the unvaccinated. What I'll show you is that there are so many inconsistencies and missing information in the data, as is the case for most studies into COVID vaccine effectiveness, that few conclusions can be drawn other than it provides no real evidence that the benefits outweigh the risks. But before I present these results, it's important to provide some background and context for those who might assume that I'm some kind of anti-vax conspiracy theorist, which is incidentally something I've been accused of. Because my research group specialises in quantitative risk assessment using causal Bayesian network modelling, and because I was the principal investigator on a major interdisciplinary project dedicated to using our modelling methods to improve medical decision making, it was inevitable that we would be drawn into the analysis of COVID data right from the start of the crisis in March 2020. Now, in the first few months, we developed causal models to explain and predict the very big national differences observed in COVID case and fatality rates. And this work was very widely published. So this was the first of two articles we had published very early on in the conversation, which attracted many hundreds of thousands of reads, and they were picked up by many international news outlets. The work was also published in prestigious reviewed journals, and we were among the first to conclude, using our Bayesian analysis, that infection rates were much higher than what was being reported at the time, while infection fatality rates were much lower. So the disease was far more widespread than was assumed, but far less deadly. We also did extensive work predicting that contact tracing for COVID would inevitably fail, and also work on the different risks to different types of populations. With our many clinical partners, we developed a comprehensive Bayesian network model for personalised COVID risk assessment. And this model was implemented for web and mobile phone use. And you can run it yourself here, although the data has not been updated for over a year. At last count, I've been co-author of 29 papers about COVID risk and statistics, and you can see the full list of papers here. But with one minor exception, none of the most recent 12 have been accepted for publication. And that's because we started to challenge some of the official narrative. And in particular, it became clear from about September 2020 that the entire COVID narrative was being driven by a fundamentally flawed approach to the definition of what constituted a COVID case. So specifically, a case was just a positive PCR test. Now, even if we ignore all the arguments about the accuracy of PCR tests, there's no dispute that many perfectly well people, i.e. asymptomatic people, test positive, and that many of these never go on to develop any symptoms. Now, up until the summer of 2020, the only people who really got PCR tests were those with severe symptoms and NHS frontline staff. But from September 2020, this all changed with the rollout of mass testing. And this means that case numbers would inevitably rise irrespective of whether the virus spread was increasing or becoming more dangerous. Now, case numbers were also being used to make decisions about further lockdowns, and that was something I was personally opposed to on grounds of lack of any cost-benefit analysis, infringement of civil liberties, and the fact that the poorest in society were the most disadvantaged by these. So we started looking at key indicators other than case numbers. The most obvious and easily available of which is the NHS dashboard data for COVID triages, i.e. 999 calls, etc. So here is a plot that I captured from December 2020. And this is very revealing because the triage data here shows the real epidemic, which took place in the spring of 2020. But the autumn-winter peak was nothing much more than a normal flu season. And that's in stark contrast to what the case data was saying. So you've got this massive ramp up in cases, and this of course follows the massive increase in the number of people tested. And of course, it's this data which led to the second major lockdown, which we didn't really get out of until the summer of 2021. And incidentally, this difference continued. Here's the data from May 2021, where there you can see the COVID triages. So these are people who are genuinely ill with symptoms. And just compare that with, again, the number of cases, people testing positive. Now, as the PCR test is also used to determine what constitutes a COVID hospitalisation and a COVID death, my view is that the official COVID data for these is essentially useless. And all these issues really came to the fore when we looked at the propaganda campaign mounted with what we believe was misleading data. And of course, this is the one that really sticks out. This started last autumn and kind of like carries on today. It says that around 1 in 3 people who have COVID-19 have no symptoms and therefore can pass it on without knowing, etc. Now, what is true is that when the virus is fairly widespread, around 1 in 3 people who test positive have no symptoms. And the proportion is actually much higher when the population infection rate is very low. In investigating this claim, we found out very important information about the true extent and impact of false positives when testing asymptomatic people. And we got this from a study of asymptomatic students that took place at Cambridge University. And during this period, an average of 5,000 asymptomatic students were tested each week, and there were 6 term weeks in the period. For efficiency, they were tested in pools, so samples from typically 2 to 5 students were tested in pools. And this was very careful testing. Now, if a pool tested positive, then each individual sample was subject to a confirmatory PCR test. It turned out that over the entire period, 43 out of over 10,000 pools tested positive, so a very small number of asymptomatics tested positive. And remarkably, 36 were found to be false positives after confirmatory testing. So each pool that tested positive, they retested each sample separately, and in 36 out of the 43, all of the individual samples were negative. Now, the false positive rate is the probability a person who doesn't have the virus tests positive. Well, there were 36 false positives in just over 10,000 samples. So the false positive rate is very low, about 0.35%. But the problem is that 36 out of 43, i.e. 84% of the positives were false. Here is real-world evidence, because this was very careful PCR testing with the confirmatory testing. We know that the vast majority of asymptomatics testing positive are false positives. In each of the 6 confirmed positive pools, exactly 1 of the samples was positive. And that was all reported here. Now, problems with the PCR test also undermine the results demonstrating vaccine effectiveness, because these are based on the comparison between cases in vaccinated and unvaccinated. In large observational studies like this one, which was very widely reported in the Lancet, the reliance on a flawed definition of a case is massively compounded by the fact that there are completely different testing strategies for the unvaccinated. So while vaccinated people in Israel were tested rarely, unvaccinated were tested a lot. So if you don't test the vaccinated, you won't find any cases among them. While if you continually test the unvaccinated, you will find cases, almost all of them false positives. Now, months on, the Lancet has still not published our rapid response letter, which was just not much more than a paragraph long, highlighting the flaws in this study. And that brings us to the UK government data on vaccine effectiveness. This is a recent report from week 42, and it's interesting. What you can see is that in each of the age categories from 30 up, the infection rate amongst the vaccinated is higher than the infection rate amongst the unvaccinated. When you plot that, you can see very clearly here that the vaccinated have a higher COVID infection rate than the unvaccinated for each of the age groups from 30 onwards, which seems to indicate that the vaccine has negative effectiveness. This caused quite a bit of a stir. For example, David Spiegelhalter tweeted this was completely unacceptable that UKHSA put out what he called absurd statistics showing case rates higher in vaxxed than the unvaxxed. Now, he says that's an artifact of using hopelessly biased NIMS population estimates, where NIMS is the National Immunisation Service. It says that feeding conspiracy theorists worldwide. But of course, this is just the government's own data. But we wrote a report which actually analysed the difference between these population estimates by NIMS and the population estimates that were being used by ONS. Because David Spiegelhalter also argued that they should use the ONS population estimates and not the NIMS population estimates. But what we discovered is that there were fundamental problems with both of those. There was no reason to believe that you would get better or more accurate results using the ONS estimates. So this was all very confusing. But I'm not particularly interested in evaluating COVID vaccine effectiveness by counting case numbers because of the problems with the definition of a case. What I'm interested in is measuring the comparison in all-cause mortality between the vaccinated and the unvaccinated over a reasonable period. So to clarify why this is so, if the vaccination is working, we should see this kind of pattern for each age group. So we'd expect to see a lot more COVID deaths among the unvaccinated. So this is all assuming that COVID is as deadly as most people assume. And if the vaccine is as safe as most people assume, then we'd expect to see only a small number of additional deaths through adverse reactions among the vaccinated. So when you add up all the deaths, there's the unvaccinated deaths, there's the vaccinated deaths, we should expect to see the number of all-cause mortalities amongst the unvaccinated to be higher than those among the vaccinated. Now, the beauty of this approach is that it completely bypasses the problem of defining what constitutes a COVID case or a COVID-related death. And as we've seen, these definitions can be easily manipulated to fit different narratives. So what we're interested in is comparing all-cause mortality. And we'd expect to see this kind of scenario if the vaccine is effective. The problem is that we already know, even from the Pfizer study, although the numbers are very small, that there isn't great evidence for benefits of the vaccine in terms of all-cause mortality. So if you look at the number of deaths in the vaccine arm as opposed to the placebo arm, it turned out that there are 21 deaths after 6 months in the vaccine arm compared to only 15 in the placebo arm, which isn't, of course, statistically significant, but nevertheless, it's not what you would expect or hope to see if the vaccine was as effective as claimed and if COVID was as dangerous as claimed. But there is a very major problem in looking at mortality data associated with vaccination, and that is that unless you age categorize it, it will be confounded by age. Now, to illustrate this, here are the actual reported COVID case and death numbers in June 2021 from Public Health England. And this is data which also caused a major stir at the time. So what you can see is that in the vaccinated, there were 27,000 cases and 70 deaths, which mean that there were 257 deaths per 100,000 vaccinated people, compared to only 82 per 100,000 for the unvaccinated. So the mortality rate is 3 times higher in the vaccinated and the unvaccinated. But this was not evidence that the vaccine was not working, because if you actually dug down into at least two age categories, those aged at least 50 and those aged under 50, in the at least 50 category, that's where most of the deaths are. And of course, there are far more vaccinated cases than unvaccinated cases here. And so there, what you can actually see is that the mortality rate in the unvaccinated is 4 times as high than the vaccinated. And for those aged less than 50, again, very few deaths here, but most of the unvaccinated are in this category. And you see, therefore, the COVID mortality is a bit higher in the unvaccinated. So in both age categories, the mortality rate is higher in the unvaccinated than in the vaccinated. So you've got a complete reversal of the aggregated result. You can just add these up to see there's no fiddling going on here. This is the real data. This is the thing we should be focusing on, the age categorized data. And this, incidentally, is a real example of a statistical paradox called Simpson's paradox, which is why you need, in the case of mortality data, to have the age categorized data to avoid this paradox, this confounding effect of age. And that brings us on to to this latest ONS report. So because this report is on deaths by vaccination status, this should give us the necessary all-cause mortality comparisons between the vaccinated and the unvaccinated, and hence enable us to determine whether the benefits of the vaccine outweigh the risks. Now, previous versions of this report didn't provide the relevant age categorized data, and that made it essentially impossible to draw any firm conclusions. But as a result of our own Freedom of Information request and direct discussions with the authors of the report listed here, the ONS included some age categorized data in this latest version. But the problem is that the age categorizations were 80 plus, 70 to 79, 60 to 69, and 10 to 59. And that younger age categorization was far too coarse. So although when we produce a weekly plot of the unvaccinated against people with at least one jab, that's the vaccinated, it seems that the mortality is much higher in the vaccinated compared to the unvaccinated. But the problem is, because this age category is so large, it's likely that this is still confounded by age. And indeed, when you look at the older age groups, this is the 60 to 69 group, and plot the all-cause mortality, here you can see there's significantly higher all-cause mortality in the unvaccinated than the vaccinated. But there's something strange here, because there's a peak here, and that peak occurs at the same time as the first vaccine rollout for this age group peaks. That's something to note. We go on to the 70 to 79 age group, and again, we've got a higher mortality rate in the unvaccinated than the vaccinated. But again, we've got this strange peak, and it comes at the same time as the first vaccine rollout for this age group peaks. Notice that's an earlier peak because the older age group had the rollout earlier. And then we go to the oldest one, which is the 80 plus group, and the same phenomenon, which is that, again, higher mortality rate in the unvaccinated, but with this strange peak at the same time as the rollout peaked for that age group. Now, these peaks are pretty strange, but there are even stranger things that you observe in the data. There are three categories of vaccinated. There are those within 21 days of the first jab. That's these guys. There are those at least 21 days. That's these guys. And those who are at least 14 days after the second dose. And what you can see here is we've got apparently this deadly first dose until you get the second dose. It's killing people at a ridiculously high rate. Whereas you've got this miracle life-saving second dose. And the point here is that these are very, very far away from the normal mortality rate. So something is not quite right here. But you've got another problem. If you look at the other than COVID mortality rate, and this is in the 70 to 79 age group, but it's the same for all the others, again, you're getting this weird phenomenon. Now, we're only considering non-COVID deaths. So it doesn't make sense that the mortality rate for the vaccinated should be lower than the unvaccinated. If the vaccine wasn't doing any harm, we'd expect these to be the same. If the vaccine was doing some harm, we'd expect this line to be slightly above that line, but no justification for this. Why would it be the case? This is the peak rollout for this group. How is it possible that the unvaccinated suddenly have this massive peak in non-COVID mortality? It's simply impossible. And then we find there are some simple but strange errors in the ONS weekly population totals. So this is straight from the data. And the thing about the ONS data, it's a very specific set of people. It's the set of all people in England who were both registered in the 2011 census and were registered with a GP in 2019. And that means that each week, this population must decrease by the number of deaths the previous week, because nobody gets added or taken away except those who die. And what you can see here is that's exactly the case from the 9th of April onwards. The difference between the expected and total population here is 0. And yet in these early weeks, we've got this massive error. And it's pretty consistent up till the 12th of March. There's sort of consistently 10,000 people somehow are added to the population each week. So what are the explanations for the strange data that we're observing here? Well, it could be systemic misclassification, both of unvaccinated being erroneously classified as vaccinated, But it could also be that within the 3 different categories of vaccinated, there's misclassification. So someone who is double-dosed might be classified as single-dosed. It's almost certain that this is going on. There's also the possibility that you could have systemic self-selection for the vaccination causing unusual jumps. So, for example, terminally ill people close to death go unvaccinated. They decide that there's no point in being vaccinated if they're going to die anyway. And on the other hand, maybe only the healthiest people are choosing vaccination. The problem with those are that there's very little evidence of that self-selection bias happening in the UK. We believe it has happened in other countries, but not in the UK. In the UK, people who were particularly at risk, people who were close to death, who had massive comorbidities, were the ones who definitely got vaccinated early. And if anything, it's the healthy people, or those who already had COVID, who maybe choose not to get vaccinated. So no evidence of those. There is evidence of systemic underestimation of the proportion of unvaccinated. And that's something that we've reported from earlier studies. Now, although I'm not saying this necessarily happened with this data set, you can simulate the kind of observations you're seeing in this ONS data by doing nothing more than delaying the reporting of death by 1, 2 or 3 weeks. Let's imagine a hypothetical situation where we've got a population of 1 million, where we're ramping up the vaccination over a number of weeks. So we start off with, in the first week, just 0.5% of vaccinated, increase it so that by week 10 we've got 80%, and week 12 we've got 98%, most of the population vaccinated. And each week we're going to record the number of deaths, so the following week the population decreases by that number of deaths. So here's the total population vaccinated, which is just that percentage of the population. But let's assume that instead of a vaccination, this is a placebo vaccination. So we know it doesn't change anything about the mortality rate. And if the normal mortality rate is, say, 15 deaths per 100,000, then it stays that rate all through. So in a population of 1 million, you've got, on average, every week, you're seeing 150 deaths. These are going up as the population of vaccinated increases. These are going down as the number of unvaccinated decreases. But the mortality rate is the same. What I'm going to do here is nothing other than shift the reporting of deaths down by 1 week. So just watch what's going to happen to the mortality rates in the vaccinated and the unvaccinated when I do this shift down. So here's the shift coming down now. I've just shifted them down, and look how the mortality rates change just by that simple shift of 1 week. We've got low mortality rates creeping up for the vaccinated, and the unvaccinated, they're shooting up at the same time as the vaccination program peaks. And if we plot that, what we're seeing here, again, the unvaccinated mortality rate is consistently above the vaccinated, with this peak at the same time as the percentage vaccinated peaks. And it appears that this placebo is very effective because it's causing a much lower mortality rate in the vaccinated. And that pattern we can now compare to the actual observed pattern. So this is what we saw in the 60 to 69 group. Very similar pattern. In fact, we saw it for all of the age groups. Now, I'm not saying a 1 week shift is happening in the ONS data, but it gives a feel for how simple errors and shifts in the data have a major impact on the observed data. In fact, we believe that misclassification and underestimation of the proportion of unvaccinated is having the real impact here. So what we're doing is running simulations with, for example, estimates of the misclassifications based on previous year's mortality data. So here's the non-COVID mortality rate for the 70 to 79 age group. And what you can see here is in the steady state, the non-COVID mortality rate is on average 40% higher in the unvaccinated when it should be the same or lower. So we can take information like that and compare it with historical life table mortality data to estimate the level of misclassification. And when we apply those estimates to the data, we get these adjusted plots. And in this case, the only unexplained observation now is this increased non-COVID mortality in the vaccinated shortly after vaccination. So in conclusion, all COVID data, which is driven by the idea that a case is synonymous with a positive PCR result, is easily manipulated and potentially misleading. And in particular, vaccine effectiveness studies are generally flawed because of that reliance on determining whether a person becomes a case or not. Now, the simplest and most objective way to determine the overall risk-benefit of the COVID vaccines is just then to compare all-cause mortality between the vaccinated and the unvaccinated, where by vaccinated we mean people who've had at least one jab. That gets around a whole load of problems of definition, of not just whether someone's a COVID case, but also whether they're vaccinated or not. The latest ONS report on mortality by vaccine status we've seen should provide the necessary data, but it's flawed in many ways. The impossible observed data could be explained by misclassification, delayed reporting, and/or underestimation of the proportion vaccinated. And if we adjust for those, we reach coherent but very different conclusions. But as it stands, the data provides no real evidence that the benefits of vaccines outweigh the risks.